So good afternoon. I'm Dr. Christopher Janson. I'm the PI on gene therapy for Canavan disease, CAN-GT, which is sponsored by Myrtelle. And I'm pleased to present the interim 6-month data from our ongoing study. So first of all, I'd like to briefly discuss what is Canavan disease. So Canavan disease is a rare genetic neurological disease with devastating clinical consequences. It's categorized as a pediatric leukodystrophy, meaning that the brain white matter does not properly form and in fact is destroyed over time. Clinically, Canavan disease is distinguished by 3 cardinal features: macrocephaly, or an overly large head, poor head and neck control, and severe psychomotor retardation with inability to walk, talk, or basically perform any age-appropriate behaviors. Currently, there is no FDA approved drug treatment. So Canavan disease was named after Myrtelle Canavan, a Harvard neuropathologist, and it seems appropriate that the gene therapy company Myrtelle was named in her honor. Now, what she described approximately a century ago was a spongiform pathology of the brain where the brain became waterlogged like a sponge. Van Bogert and Bertrand were Belgian neurologists who subsequently showed the pathology involved myelin and white matter exclusively. But it wasn't until the 1980s that Kvittingen first described the role of elevated NAA in Canavan disease, what turned out to be Canavan disease, and the genetic defect was discovered by Madelon and collaborators in the 1990s, thereby enabling gene therapy to happen. What we now know is that Canavan disease is caused by mutations in the ASPA gene for aspartoacylase, an aminoacylase enzyme which breaks down NAA into acetate and aspartate. When this gene is missing or damaged, NAA increases to high levels throughout the brain. Effects include insufficient N-acetyl group substrate for myelin synthesis, as well as direct osmotic damage to myelin from local effects of high NAA. So just a little bit of history. I've been personally involved in drug development for Canavan disease for over 20 years now. In 2001, with my colleague, Dr. Paolo Leone, we conducted the first clinical gene therapy for Canavan disease with an AAV2 ASPA vector. And this was the first application of AAV for a neurological condition. At the time, there was no vector specifically targeting oligodendrocytes. The development of an AAV vector with tropism for oligodendrocytes took about 16 years through capsid mutagenesis studies by Steve Gray at UNC, who also joins us today. AAV-olig was really a breakthrough as the first AAV vector showing strong tropism for oligodendrocytes through capsid-host interactions. As you know, most existing AAV, and as we just heard, most existing AAV vectors are strongly neurotropic. AAV-olig is unique in its ability, or nearly unique, to specifically target oligodendrocytes, which are the main cell type involved in Canavan disease. So the drug product has already garnered a number of key designations, including FDA Fast Track and Orphan Drug Designation and EMA Orphan Drug Designation. So there are a number of features of Canavan disease. Right here, which make it an ideal gene therapy candidate. Number one, it's a single gene disorder, so gene replacement therapy is feasible. Number two, there's a well-defined cell population in the CNS which can be neurosurgically targeted. And number three, as a consequence of the brain-specific targeting, a relatively low dose of vector can be used, which makes it less likely to result in immunological complications and scalable, so more patients can be treated. The AAV-olig vector shown here at the bottom expresses ASPA predominantly in white matter. And in mature humans, unlike in rodents or other species, This constitutes almost half the adult brain volume. So specifically, AV olig expresses ASPA in proximity to myelin sheaths, which should decrease local NAA and prevent osmotic damage while simultaneously promoting myelination. So for this first-in-human study with AV olig, we enrolled 8 patients who were treated with a fixed dose of 3.7 times 10 to the 13th vector genomes. We performed direct neurosurgical delivery to the cerebral ventricles and surrounding white matter using either 2 or 4 delivery catheters introduced through burr holes. In addition to safety, our primary clinical outcome measures are the gross motor function measure, or GMFM, and Mullen scales of early learning, both of which we selected in our original gene therapy study 20 years ago. In my opinion, these outcome measures are among the best available tools for detecting meaningful clinical outcomes in Canavan disease, and we have decades of natural history data to refer to. All of our surgeries and follow-ups are currently being done at Dayton Children's Hospital in Dayton, Ohio. Some of the secondary outcome measures include non-invasive imaging with synthetic MRI or psi-MRI, a quantitative and rapid method to measure white matter, myelin, and brain water content. In addition, NAA levels are precisely measured in the brain using MR spectroscopy. We're using quantitative modeling of NAA concentrations using LC model with standardization to a phantom. So study inclusion criteria include a definitive diagnosis of typical Canavan disease by a board-certified neurologist, sequencing for identification of gene mutations, and age between 3 and 60 months at the time of treatment. Some of the exclusion criteria include the presence of a known mild mutation, of which there are a number, clinical features suggesting a mild phenotype, such as a GMFM score, raw score of greater than 35% of goal, and any medical contraindications to surgery. So this table shows our patient characteristics, which, as you can see, are roughly half male and half female and span an age from 11 to 58 months at the time of treatment. The oldest and sickest patients were treated first. There was a hiatus in enrollment between patients 1, 2, and 3 and patients 4 through 8 due to vector production issues, and thus we currently have 6-month data on all patients right now, but are still collecting the 12 to 24-month data on later patients. As you can see, they come from all over the world, from New York to Alaska, and 5 foreign countries, including Chile, Argentina, Slovakia, Russia, and Italy. So I'd like to present some clinical vignettes from the Canavan Neurological Exam, or CNE, which includes videotape components. So this is a patient prior to gene therapy, that's me at the left, showing significant head lag and floppiness in the supine position. Then 3 months after gene therapy, the same subject shows improvement in head control, truncal stability, and gross motor function, including taking some steps with assistance. At 6 months post-gene therapy, at right here in this patient, we observed increased cognitive performance as well as the ability to stand from a sitting position and ability to stand upright without truncal support at the right, shown here with his physical therapist during a therapy session. So moving on to some quantitative data, grab the pointer. So starting here at the right, I'm sure this is working, but starting at the right, we have GMFM subscores of lying and rolling and sitting, which both show a favorable trend in the change from baseline raw scores. Then when the data are aggregated at left, the total change from baseline raw scores were statistically significant. This result is consistent with clinical observations of improved head and truncal control, which we believe are clinically meaningful. And we expect that these data will coalesce at the 12 and 24-month time points as we collect longer-term data on patients who were treated at a younger age. So the Mullen Scales of Early Learning is our other primary outcome measure, which tests a number of different clinical areas from the GMFM. It has non-overlapping gross motor function items as well as fine motor, visual reception, and receptive and expressive language. So these tests were done by a trained psychologist or medical doctor. And as you can see, we saw the same trend and improvement in gross motor scores as with GMFM, with a slight inflection point at 3 months and then improvement in mean scores across all categories at 6 months. There was considerable inter-subject variability at baseline, but these data are represented as change from baseline scores for all patients. Of note, there were statistically significant changes in both receptive and expressive language at the 6-month time point, with some subjects showing emerging language and reasoning skills. As I mentioned before, brain imaging is a secondary outcome measure. We chose to use synthetic MRI or psi-MRI, a fully quantitative FDA-cleared method which uses a very short scan time to derive all the required sequences. It can precisely measure brain water content, myelin, white matter, gray matter, and other relevant parameters. Remarkably, even with a limited data set at 6 months, we detected statistically significant changes in a number of key areas relevant to Canavan disease. There were large post-treatment water shifts, measured both in CSF volumes as well as intraparenchymal water. The CSF volumes are shown at top left. In addition, we saw preservation of brain structure or lack of significant progression of brain atrophy, evident with increasing brain parenchymal volumes and white matter volumes. Across the board on all patients, we observed increases in healthy myelin signal, which were on the order of about 10 mLs new myelin for all patients, which is, I believe, on the bottom left. So these are representative slices using synthetic MRI. They show brain white matter content for 3 different subjects at baseline and at 6 months post-treatment. The software sums over all slices, axial slices, to generate a total white matter volume for each patient. We observed variable increases in myelin across all the treated patients, which ranged from approximately 40% increases up to doubling of white matter content. These data, in my opinion, are extremely encouraging, using myelin as a direct biomarker of disease progression rather than an indirect biomarker such as NAA, which we're also collecting. Due to time considerations, I'm not presenting our quantitative NAA data today, but I'd just like to state that we've observed a clinically significant decrease of brain NAA with MRS on the order of several millimolar using single voxel MRS with our normalized LC model. In terms of adverse events, this is obviously an important part of a phase 1/2 study. There were no SAEs related to the drug, although 2 SAEs were probably related to the neurosurgical procedure. These involved a CSF leak and an episode of focal motor status epilepticus related to a catheter placement. We mitigated the risk of future SAEs through minor modifications of the neurosurgical procedure, including a change in the method of catheter insertion, changes to the skin closure, and measuring CSF pressures with pre-surgical lumbar drainage in selected patients. Some of the other SAEs included generalized seizures in some patients, which we believe are related to the natural history of Canavan disease, along with concomitant illnesses such as COVID or other viral infections. 2 out of 8 of our patients contracted COVID and recovered fully. So as PI and on behalf of Myrtelle, I'd like to thank all of our collaborators at Dayton Children's Hospital who made this study possible, including my co-PI neurosurgeon, Dr. Rob Lober, and his assistant, Tricia Ferris. I'd also like to especially thank Dr. Paola Leone and Dr. Jeremy Francis at Rowan University for this 25-year journey with Canavan disease, which we've been on together since we were at Yale together. Finally, I'd like to thank all the patients and their families for their resilience and commitment as we try to bring this novel gene therapy to the clinic. Thank you.